Yeah. A little teeny bit. I can get those F's.
Well, welcome everyone to this official press conference of AIDS 2016. And this, the focus of our discussion today is about protecting the most vulnerable populations. My name is Beyrer. I'm the president of the International AIDS Society, and I'm serving as the international chair for this conference. This briefing is being live streamed on the IAS conference YouTube channel and will also be archived there for future viewing. Today, my colleagues on the panel and I are going to address an issue at the very heart of the global HIV epidemic, and that's the importance of protecting those at greatest risk from HIV/AIDS. And that includes, of course, men who have sex with men, transgender people, people who inject drugs, sex workers, and prisoners. We'll never be able to end AIDS without addressing the needs of these most vulnerable individuals and communities, and yet we know, in 2016, far too many are being left behind. In 2014, these vulnerable groups accounted for more than a third of all new HIV infections. So that was really an extraordinary proportion of HIV. Transgender people are 49 times more likely to be living with HIV than other adults. That makes them the most heavily HIV burdened of any of the key populations. Men who have sex with men and people who inject drugs are each about 24 times as likely to become infected with HIV as other reproductive age adults. And sex workers are about 10 times as likely to be infected. Prisoners about 5 times as likely to be infected. So these are really extraordinary burdens, and what these populations share is both high burdens of HIV and low access to the essential services that would help them protect themselves and get treatment. So this truly is the undone work of the HIV response, and this is where, unfortunately, we're seeing the highest rates of new infection. If there's any silver lining in this cloud, it's this. We're talking about a relatively small number of people who are at high risk of infection relative to the world's population. And that means that turning this around doesn't require vast new commitments to very large populations. What it does require is an honest acknowledgement of where the epidemic is hitting hardest and directing resources to that need. Unfortunately, we're not there yet. Discriminatory laws continue to block access to HIV prevention and care, and screening and treatment programs are rarely tailored to reach these groups as effectively as they could. I want to just make the point that protecting human rights is not just a moral issue, although it is a moral issue, it's also a scientific issue. Research presented at this conference is going to demonstrate that exclusion and discrimination can fuel the spread of HIV and reduce the likelihood that people seek testing and treatment. I'd like to take a brief break and speak specifically to the needs of people who inject drugs before my colleagues address the other populations. So I recently had the privilege of serving on the Johns Hopkins Lancet Commission on Public Health and International Drug Policy, and was the lead author of the Commission's report that we issued in March of this year. And this was done for the UN General Assembly, a special session on drug policy. And we reviewed the available evidence around the world, and we found that drug laws, which were put in place and which were intended to protect the health of the public, have instead contributed to disease transmission, discrimination, legal violence, forced displacement, and have actually undermined people's right to health. So when it comes to drug use in HIV, evidence-based public health policies and approaches have too often been rejected by government policymakers. The result of this neglect is the rapid spread of HIV, trampling the human rights of people who inject drugs, and ultimately unnecessary human suffering. We know what works for people who inject drugs, and that includes needle and syringe exchange and opioid substitution therapy. And it took up and acknowledged the importance of these and other evidence-based solutions. The HIV epidemic is going to continue to take a devastating and easily preventable toll among people who inject drugs. Before I turn to our panel, I'd like to exercise the chair's privilege and draw attention to two relevant press conferences that are happening outside the official press briefing. So today at 4:15, The Lancet is organizing a briefing for its series on HIV and related infections among prisoners. That's Tuesday at 4:15. I wrote a commentary for that and co-authored authored many of the articles in that issue. I can tell you it's really going to be quite extraordinary. The other press conference is at Wednesday at 2 p.m., where Johns Hopkins, IAS, and the others are going to launch a special issue of the Journal of the International AIDS Society, looking at policing human rights in the HIV response. And we have speakers from PEPFAR, the Global Fund for AIDS, and country representatives who are implementing successful policing programs. So I encourage you to please attend. I'd now like to introduce our first speaker, Francis Cowan, from University College London. Francis is the Executive Director of the Center for Sexual Health and HIV Research Zimbabwe, and the lead author on the Aher study, which is the largest study of its kind evaluating strategies to enhance HIV treatment and prevention among female sex workers in Zimbabwe. And this is really a landmark study in this field. Francis.
So good morning, everybody, or good afternoon. Very nice to be here. I'm going to talk to you about the Sapphire trial, which was specifically designed to see if we could improve the health of sex workers living in Zimbabwe, but learn lessons that are applicable to the rest of Africa. So I'm sure all this audience know that sex workers in Africa bear the brunt of the HIV epidemic. They have prevalences in the region of 50 to 70% and very high incidence rates. We also know that they're very poorly linked to prevention and care services when you compare them with the rest of the population. We know that services led by sex workers that are community-based are the ones that are most likely to result in improvements in care and prevention. Now, Zimbabwe's been very forward-thinking, and in 2009 they set up a national sex work program through the National AIDS Council, which we run in Zimbabwe, and that's now on 36 sites around the country. That program implements sex work programs as outlined by WHO. The aim of the Sapphire trial was to see if it was worth intensifying that provision to provide antiretroviral drugs directly to sex workers through that program if they were HIV infected, and to provide pre-exposure prophylaxis to them if they were HIV negative, and provide community-based adherence support. So this was a trial where we randomly assigned clinics to either the usual Sisters program, Sisters with a Voice program, or the enhanced Sapphire intervention. And what did we show? Well, those of you who've seen the abstract will show that we increased uptake of access to services amongst women in the intervention communities. The second thing that we showed was that at the start of the trial, around a third of sex workers, all sex workers, not just those living with HIV, had detectable viral load, which indicates that their HIV infection was not properly controlled. By the end of the trial, that had significantly reduced in both arms of the study. So in the sisters-only arm, we had managed to reduce the proportion of women living in those communities with a detectable viral load down to 19%, and that was further reduced in Sapphire communities to 16%. The difference between communities wasn't statistically significantly different, but this is still good news, I think, that the engagement of women in care is so much improved. When we look at how we achieved that, you can see improved uptake in all aspects of the care cascade among women in both arms. UNAIDS has set the target of achieving 90-90-90 by 2020, and in both arms of the study, sex workers were already engaged at least 80-80-80, and probably 85-85-85 in the intervention Sapphire communities. So that's great news. So just to summarise, sex workers remain at very high risk. It seems that intervening with programs really can help engage improve both their own health and the likelihood that they might infect other people. And the data don't suggest that we need specifically to provide ART on site, but that we just need to run comprehensive services for them. So I think that's all I was going to say.
Thank you, Francis. It's really very, very compelling work. Our next speaker is Jakobsson. She's the president of the Global Network of Sex Work Projects. She's advocated for the rights and well-being of sex workers since the 1990s. She co-founded the Rose Alliance in her native Sweden. She helped establish the International Committee on the Rights of Sex Workers, and she sits on the advisory board of the Global Coalition on Women and AIDS. She'll be offering further insights on HIV prevention and treatment needs of sex workers. Hi.
Very well. Sorry about rushing in late. It pointed me in all the wrong directions. I'm a bit flustered. I'm afraid I'm going to complicate things just a little bit further because that's what I do. And I think that while I think it's instrumental that we get all sex workers living with HIV under treatment, I would argue that not all sex workers living with HIV are yet in treatment, and yet somehow lately we're focusing a lot on that. Now I think that's a great intervention when it goes to sex workers who want it, willingly accept to take it with the adequate and enough information, rights-based information on how it's going to be implemented. Yet it worries me a bit when studies are done that we know nothing about, and we are talking about the Global Network of Sex Work Projects, and specifically the African Sex Workers Alliance that are all over Africa that should have been involved somehow, I think, in this trial. So I'm missing that part. And then I just, as a little parenthesis, I want to say that I object to the phrase saying that sex workers will possibly affect other people. I think we all have to take responsibility for our sexual health. That said, I think that we are right now we're facing a lot of challenges in the field of HIV. And I know that the experiences of sex workers and the opinions of sex workers in regards to specifically PrEP are very, very diverse. And they're diverse for many different opinions, but the reality is that in some settings, sex workers know that they are likely to be exposed to HIV, they are likely to maybe become positive, but then if they do become positive, they are unlikely to receive treatment. And then PrEP seems like a pretty good idea. I think we are still we have a long way ahead when it comes to making sure that people who do engage in taking PrEP have the information they need to actually understand the implications it has in their lives. And I really applaud you for trying to work according to the guidelines of the WHO and the SWIFT tool I hope you're referring to, which I was lucky to be part of developing. It also really points out that not only is sex workers and sex worker empowerment at the center, but sex workers' chosen representatives. And that doesn't mean picking up a random sex worker here and there. It actually means the representatives we have chosen for our rights-based organization, in this case, the African Sex Workers Alliance. And for the future, I just encourage you to hopefully involve them as well. And then we will truly live up to this picture. Thank you.
I'd now like to welcome Bisi, Alimi, one of Africa's leading LGBT and HIV advocates. Bisi was the first Nigerian to openly declare his sexuality on national television in 2004, so a true pioneer. And he's been in a whirlwind of advocacy since. Today, he's executive director of the Bisi Alimi Foundation, which works to improve the lives of LGBT people in Nigeria by accelerating social acceptance through training, research, campaigns, and advocacy. Bisi.
Thank you very much, Chris. Good afternoon, everybody. I think personally for me, it's very exciting to be here at a very critical point in the fight against HIV. First is the fact that 10 years ago, a wonderful organization was formed, the Global Forum for Men Who Have Sex with Men and Gay Men. And that particularly became the turning point in our activism for HIV and MSM and gay men. And for the first time, we actually had a voice at the table, and we're actually able to articulate our issues. We're able to give ourselves a platform and get projection. The organization is 10 years today. Oh no, it's 10 years ago this conference. So if you are at the last, you can stop over at the local village and sing happy birthday for them. But to get on the more interesting issues, we know that a lot has happened since the last time we were in Rome. And I can be telling everybody, we are now back in Dublin, and if you belong to the social media world, this is going to be Dublin 2.0. But in the last 16 years, the question remains, what are the issues that have been affecting us as a community? And while we have achieved a lot, irrespective of how we look at the fight against HIV, there is a particular community that has been left behind alongside drug users and sex workers, and that is the men who have sex with men and gay men. We know that globally the incidence of the virus in general population is coming down, but amongst gay men is still between 10 to 24%. Even in the so-called high income country, the story is still the same. At the moment, a lot of us are fighting tooth and nail to be able to have access to PrEP. For example, the UK has the biggest study on PrEP, which is called PrEP, that proved that if you give gay men access to medication, to PrEP, it will reduce the spread of virus, but the government has refused to do that. And that is at a point where access to medication for HIV treatment is relatively progressive. And even more to on the continent of Africa, there are a lot of questions that we need to ask ourselves. We know PrEP works, but who is ready to pay for it? In settings where increased criminalization is very high. For example, I'm from Nigeria, and January 2014, Nigeria signed into law the Anti-Sex Prohibition Act that actually stipulates 10 years in prison for anybody who provides services for non-opposite homosexuals. Services were not spelled out, but the system include access to HIV treatment and HIV prevention. In as much as we're fighting this battle to reduce the virus, these are challenging situations that we find ourselves. There's a need for investment as well. And where investment or where morality determines investment, gay men are mostly left out because in most of the settings their sexual behavior is seen as being abortion. And within that context, they are not included in the HIV framework of their countries. And even when they are included in the framework of their country, it's at a very high patronizing level, but the voices are not heard. Other people are speaking for them. And I'm happy that the global declaration is looking at inclusiveness. But I'm hoping that this is not just going to be another talking point. There is a huge need for political willpower that will go beyond what we have had in the 2000 and what we had in Vienna in 2010. I think we can't sit back and hope for it to keep doing the same thing and expecting a different result. But before I leave, I know this has been said many times, I think it's important for us to reestablish this. Because of the stigma, discrimination, and criminalization on the continent of Africa, a lot of men who are having sex with men are also married to women. If indeed we are serious about getting rid of the virus, let us get rid of stigma, of discrimination, and end criminalization now. Thank you.
Bisi. That's a powerful message. We really appreciate that. Our next speaker will address perhaps the most marginalized and vulnerable populations we're focusing on today. Abhina Aher has been working in the field of HIV for 20 years. She serves as chair of the Asia Pacific Transgender Network. She also works at the national level as program manager with the India HIV/AIDS Minds, and then was on the steering committee of the recent UN high-level meeting on AIDS. She sits on a number of boards where she advocates for transgender rights and funding for transgender health. Abhina.
Thank you so much. My name is Edwin. You know what? I mean, I'm kind of a person who belongs to human life. In the last 3 years, I have lost almost 7 of my transgender sisters, or close to my family. And that's a huge number. Some of them have died when they were in the terminal stages. Some of them have died because they could not express that they are HIV positive because they were scared that they would be further stigmatized within the trans community. And some of them have died because they did not have money to go there in centers where they are. And that's the harsh reality that we are facing. Let's just talk about that at least 49% of transgender percentage is more likely to get HIV positive infection. Right now the issue that the transgender community is having is that for a long time, almost if you look back, for 4 years or 5 years back, most of our data was counted under MSM umbrella, which is men having sex with men. They still trying to get out of the label of a man. We are not men, we are transgender women. And we need to have different resources, we need to have strategies, we need to have a data that would really count numbers. We are right now in the 21st International Conference, and it took us 21 international conferences to have first trans P conference which we had yesterday, which says that no more lip service. Because we are always hearing from the people that people are only talking about transgenders, but people are not able to act on the transgenders. A lot of donors, a lot of stakeholders, a lot of policymakers have been hearing about the transgender people for years. They still don't know what they're going to see if I get undressed. And that's the harsh reality. Our healthcare systems are not equipped to deal with the trans issues. We do not have enough capacities within the trans networks, within the trans organizations to implement the program. I still have to say with the pity that a lot of trans resources go to the organizations who are not trans-related organizations. We are not incapable. We are the trans people, and we can solve our own problems if donors and organizations can just get us involved into our data collections. A lot of the trans people are educated, they are PhDs, they are doctors, and they are. I handled myself a 26 billion program, which is the largest ever medicine transgender program introduced by the Global Fund in India, with 400,000 medicine transgenders, 200 organizations, and 6 regional partners. And I'm a transgender person from India. If I can do it, all my sisters and transgender people can do it. Right now, what we need at this point of time at the global level is that we have to get out of our systems. We need to recognize these individuals as transgender people. They are not just beautiful, they are intelligent people as well. We need resources. We need strategies, and within those strategies we are asking for transgender people engagement, and those engagements should not be just domestic engagement. I was looking at the CC and the deportation mechanism of Global Fund, and in only 13 countries transgenders have been sitting on the CCM boards, but in the rest of the countries transgenders are not even sitting on the CCM boards. In my country itself, there is only one seat, either MSM can get it or a transgender can get it. But that's not fair, because transgender issues are different than MSM issues. And just because we have similar kinds of sexual activities, our issues may not be similar, because our gender issues are much more different. The violence rate among transgender people, I looked at Asia as a region itself, the violence rate among transgender people is more than 68% in Asia as a region. Now I don't even have to go into the global scenario. A friend of mine who belongs to Istanbul, and Istanbul right now is my friend, Yumi, and she's she belonged to Istanbul, and she was, punished by this law enforcement agencies. All savings were taken back, and she was asked to get on Aher. Another transgender person from Pakistan, Bisi, who was been arrested at the Thailand airport. Her hair was cut down. She was asked to stay into the, male custody, and there more than 10-15 people used to rape her every day. Every day she used to get raped. She got addicted to syphilis, and she has to take a medical injection every day. That is the harsh reality of transgender people right now. And I'm requesting all the donors, stakeholders, media, and everybody to make sure that when you talk about transgenders, you just don't talk about this. We don't need any more lip service. What we need is your action. What we need is your engagement. And when you do that, make sure that we are sitting on the right table and not the beneficiary. Thank you so much.
Thank you, Abhina. Very, very powerful testimony. It's now my privilege to introduce our final speaker, Justice Edwin of the Constitutional Court of South Africa. Nelson Mandela described Edwin as one of South Africa's new heroes. He's a prominent human rights lawyer during the apartheid period, and he was the first senior South African and indeed African official to state publicly that he was living with HIV. He's well known both for his jurisprudence and his decades of advocacy on behalf of South Africa's LGBT community and people living with HIV. At the 2000 International Conference, some of you will remember, I certainly do, that he delivered a powerful plenary address on the inequities of HIV in Africa that really changed the global conversation. And now, 16 years later, we're delighted to have him back with us. Just to say, be prepared that tomorrow in the opening plenary session, he's going to give the Jonathan Mann Memorial Human Rights Lecture, which is a lecture that we do every International AIDS Conference in memory of Jonathan Mann. Edwin.
Thank you very much, Chris, and good afternoon, ladies and gentlemen. I want to start off by saying that I'm a man in a tweed jacket between three fabulous people, and if you think I'm patronizing them, I'm not. They have done things, Bisi, as a black man, and race is important, on a continent of phobia against men of sexual men. Abhina and I have done things of greater courage than I've ever done. I've always been a man in a jacket, I've been a lawyer and a judge all my entire life. I have done things from the safety of places that have been alien to my colleagues on this platform, and with real humility I pay honor and tribute to all of them. Thank you. Draw attention to the fact, the obvious fact, that today is Nelson Mandela's birthday. And it's the 18th of July, it's an important moment for us in South Africa because we're struggling to cross the meaning of his heritage, his sensibility of his mind, of his generosity, his humanity, which becomes nostalgic to time people. I don't know if you ever see anything expressly about sex workers and transgender people, but we can really guess that he was such a precious and generous human being that he would. I don't think that that's unrealistic at all. And Nelson Mandela's struggle illustrated an important point, which I'm sure that it wasn't comfortable for us when I spoke about involving sex workers, and perhaps you want to come back to what she said. But Nelson Mandela's life was based on the principle which was summed up in the struggle for African American rights, and which was nothing about us without us. As a proudly gay man, I say that too. As a proudly black gay man, I think you say that too. Abhina said the same as a proud transgender woman, and I say the same as a proud sex worker advocate. And I think we're all saying the same thing on this day of Nelson Mandela's birthday. Nothing without us, nothing about us without us. Inclusion, consultation, representation, and ownership. I also speak to you as a person living with HIV. I've been living with this virus for 31 years. I was diagnosed nearly 30 years ago in 1996. I felt severely ill with HIV with AIDS at the end of 1997. And I had the benefit and the privilege of getting on antiretroviral treatment. And that was why I strength to come and talk in the way that Chris is so generously referred to. But the same principle applies to us within the HIV. We've had to struggle, as Abhina has said, for that representation, for that ownership, for that recognition. And as I has said as well, I want to support my sisters and my brother in that struggle. And ladies and gentlemen, we live on a continent in which levels of homophobia are reported. 38 African countries, most of them in the Commonwealth. Where are the British people here? I want to be victimized. I want to single you out and victimize you. You imported homophobia and the horrible Victorian laws, the Henry VIII's law and the Victoria's laws into our continent. We haven't rid ourselves yet of this white Eurocentric homophobia. It's a long struggle ahead. And I want to reinforce the point that this is already made. The point is that starting with rights in this area is not only the right thing to do, it is the right thing to do. It's also the scientific thing to do. It's also the correct thing to do from an epidemiological, virological, epidemic management point of view. We have to protect the rights of the two populations, transgender people, sex workers. Ladies and gentlemen, laws that criminalize sex work. How do you do this? Really, switching you off. Chris, will you stop switching you off? You just say that. Ladies and gentlemen, they are the same on justice, but they are also the same on rational, scientifically based, evidence-led prevention and treatment and testing and education and behavior change efforts. The same applies to the laws that criminalize heterosexual men. The same applies to laws that criminalize people like me with HIV. We have 30 countries in Africa, and most states will last precedent now. In the United States of America, still have absurd, overstated, overbroad, very vague laws that criminalize people with HIV, not disclosing their own status and their own sex, regardless of whether, like me, they are successfully maintained as a preservative of biology, which makes them non-infectious sexual partners, also established recently conclusively by independent scientific research. I cannot answer the virus anymore, ladies and gentlemen, I assure you of that. Those laws, despite non-transmission in many American states, still criminalize people. So if you have, ladies and gentlemen, protection of key populations, protection of minorities, protection of our brothers and sisters on either side of me is an absolutely indispensable tool in dealing effectively with this epidemic. And we can get there. Thank you so much.
Thank you, Edwin, and thanks to all the speakers. Just before I open it up for questions, and when we do open it up for questions, I'll just ask you to please say your name and your media outlet, and if you have a particular question for any one or one of the speakers, just let us know that. But Francis, I wonder if you would like to take out Edwin's offer of responding to Aher.
Yes, so thank you. I of course it's uncomfortable, but I totally understand what you're saying. So the first thing I'd like to do is just reassure you. In 2009, when those services of sex workers in Zimbabwe was no association, there were women were very disengaged. The national
we open it up for questions or any questions from the audience? Please.
My name is Alimi. I'm a journalist with a Spanish interpreter. I'm working for Edwin Aher. Yes, just to know your deeper opinion about the legislation of Abhina regarding to sex workers, and if you think it's going to change soon.
I can't comment directly on that. I see there is saying on justice. I'm a judge of the Constitutional Court. That issue may come before the court. Some laws that people regard as unjust may be constitutionally maintainable. So I'm giving you the lawyer's answer. I can't do anything else. Because I should be giving that answer in due time judicial oath. If an matter comes before the Constitutional Court, I will have an open mind on the constitutional framework and the justification that the legislature puts forward for those laws. My court, 14 years ago, our majority of 65 in state versus Jordan, upheld the legislature's power to enact laws that criminalize sex. But that issue may return to the court while I'm still on it. So I won't say more than that.
Please.
Hi, so Rosh Padi from Abhina. So the question for us is, so would the sort of bottom line conclusion of your study be that the WHO package is exactly the right package and you don't need any extra interventions?
So the WHO package is evidence-based. They've really put together a combination approach that recommends both clinical services and community involvement of sex workers, and the whole programme is based in human rights. So it is a very comprehensive package of services. The extent to which it's implemented will vary, and so I think the more intensive you make it, likely the better it is, but we haven't shown that you need to provide ART services directly on site in order to be effective. But what we have shown is that sex workers, not just engaged with the programme, but sex workers in the communities where the programme was based, really have much better engagement in care as a result of that.
Alright, then if there are no further questions, let me again echo